Hey, everybody. Welcome to Distorted. Joined today with special guest, Dr. Sonja Sollenberger, a.k.a. my wife.
That's me.
That's you. We're going to talk today about, joy, depression. So we're going to talk about depression because not necessarily that there's a distortion around depression, but just because it's fairly common and it's also misunderstood and it's also overused and so all those things. So we're going to talk about maybe just briefly what actual depression is, and then we'll start to talk our way through like how to navigate it and why people get caught up on it too quickly, I think.
Are you saying that because in the culture it's more common these days for people to, I'm depressed. I'm so depressed.
Yeah, I think it's still a common thing. I think 10 years ago it was really common for people to use I'm depressed, I'm anxious. Now it's more people trying to throw out personality disorders because the smartphone has pushed them towards that. We'll probably do a whole podcast on the fact that there's really not that many narcissists out there. But that's the new version of this. The old version of this was always people throwing out I'm depressed or I'm anxious. And so that is part of it. That's part of it for sure.
The self-labeling was the part. Okay.
Yes.
Carry on.
Oh, okay. So then with depression, I think the first place I'd like to start with it is to say, of course it's real. And to varying degrees, everyone experiences time periods of sadness. And I'm going to start with this one because to me, it's the most obvious. Grief comes with it a stage of sadness. And oftentimes the first way to get off track is when sadness comes from loss, it's not depression. It's sadness because you lost something, whether it be a relationship, a marriage, a person, an actual death, an animal. Pierre and Sonny would be, those are our little guys. And so that's sad. A job, you move from one location to another and you lose the friendships maybe that you had. Loss is inevitable and sadness comes from that. That's a normal way to process loss. That's not depression, right? So that would be a big one to point out, right?
That you're differentiating sadness due to grief and loss versus
sadness due to an underlying pervasive emotional distortion of feeling foggy, of feeling under the weather, of feeling disconnected, of feeling unfocused.
Something more persistent and pervasive as opposed to something transitory.
Correct. Or because there's a reason. You can have depression. There's not an actual objectifiable reason as to why you're feeling this way. You just are. You have a malaise. You are feeling this way. It's not pinpointed on anything, right?
Right.
Okay.
Right. And the sadness, and we'll get to this when we talk about symptoms of depression, but the depression can be objective, other people saying, this is what's happening, and it can also be subjective. Like, this is depression I'm feeling.
Well, this is what I'm saying about things, and so this is why I interpret them.
It can be objective or subjective or both.
Or both.
Yeah.
Yeah. And typically when someone comes in with this type of presentation, it starts to come out in the dialogue when you start to talk about them feeling out of sorts. They'll use words like that. I'm out of sorts. I'm having trouble focusing at work. I recently had a difficult transition in something, and so I don't feel like I've recovered. So the difference between an adjustment disorder and then pure depression, right? That it's not just because they've moved into a new environment and they're adjusting to it. It's that there's a genuine feeling of disconnect to themselves and why they're doing it, like a purpose. I don't feel purposeful, you'll hear people say.
I feel off.
Yeah, I feel off. I have trouble getting up out of bed.
I don't feel like myself.
Yes. I seem to when I'm on my day off, I don't do much of anything.
Things take me longer than usual, right?
Things that used to be fun aren't anymore.
Right.
It's more labored than fun.
Right.
I don't want to go through the steps that's necessary to get myself to go do the fun thing, pack a bag.
And then the end of that would be, I'm not going to engage at all. I'm going to isolate myself.
Yeah, now we're getting to the more serious symptoms. I'm not going to get out of bed at all, even in my own home.
Right.
Yeah, I'm going to let friendships end because I don't want to put the effort into making them work. I don't.
Sad.
Yeah, it's sad. I'm not eating, even if I'm hungry, and I'm telling myself I'm not hungry. Right?
So let's talk about the symptoms of depression, right?
Go ahead, doctor.
When we talk about what comprises depression, right? So the first thing we look at is a depressed mood. That loss of interest in activities that we used to be interested in. An increase or a decrease in our appetite, eating too much or eating too little. Same can be said about sleep, sleeping too much or sleeping too little. Fatigue or a loss of energy. Having a difficulty getting up and around and doing grooming.
Basic hygiene.
Basic hygiene. That's one of the first things I would see with my clients was there was a change in their presentation and how they dressed, how they took care of their hair or lack thereof.
May I say something about that before you move to the next one?
Sure, yeah.
Significant about presentation, everybody, is that if you think about it, at the worst of the worst, there's still a maintenance of the shower, the combing of the hair for ladies, putting on a little bit of makeup, dressing in coordination where something matches something else, getting your nails did, as they say, jewelry, things that you would normally just take for granted. You have to understand the significance of those things going away. Because for a lot of people, you do those in auto, like, what do you call it? Like just
automatically.
Yeah. You're just going through the motions, but it's such a significant part of self-care. I just wanted to point out how severe that can be to somebody when they're not doing those things. You should be thoughtful enough if you see a loved one going through that to take that serious. I just wanted to point that out because that's a big one.
Yeah, when your appearance changes, it's not just, and it can go either direction, either changing your appearance so much that you're overcompensating, right? Usually what we see with clients is the opposite, is they stop doing the hygiene and the hair and the showers, and they just don't have the energy to do it. They're fatigued. They don't care as much. They're not as interested. They're not as worried about what other people think about them because they're so ingrained in what they're experiencing. But appearance can go both ways. Yeah. And people, the other end of that is a lot of makeup, overdone hair, difference in dressing, because that can become a defense and a layer of protection. So we can see that as protecting us from getting hurt internally.
Yeah. And ironic to that topic, because ADD is a terrible thing to waste, the mask that sometimes can be presented, mostly, I would say, through the female lens, but men can do it too. That's a whole nother topic that I will address at some point about the mask that is presented, but I'm going to do it through the lens of the beauty mask. But it's ironic that it touches in on this topic, that you can use it as a protection mechanism, but you can also do it even if you're not depressed. You can use the mask as a protection mechanism, and according to Hollywood, make a lot of money off of that. Anyways, go back to that. I'm sorry. A little bit of a sidetrack there.
All right. So just to recap, right? Yeah. So depressed mood, decreased interest in activities that we normally socialized in, an increase or decrease in appetite, increase or decrease in sleep, exercise, fatigue or low energy, and then where I left off was feelings of kind of worthlessness or excessive guilt, inappropriate guilt can be an indicator. decreased concentration.
That's great.
My eyes, I can't see as well anymore.
I'm laughing with her, not at her, everyone, please.
I'm 50 now. I
No negatives.
feel it. So decreased concentration.
Yes.
I'm going to pinch you. A decreased concentration.
Yes.
And then the more serious one, well, they're all serious.
We'll pause on this one too, though. Yes,
okay.
go ahead and say it, and we'll
Well,
pause.
like a suicidal thoughts or suicidal ideation.
Yeah, so the buildup to this is that the suicide ideation would be coming at the deeper end of this, so the shallow end of the deep end, if you will, if you can visualize a pool, that as you get to the deeper end of this, the attributes of the other ones are happening, and they're happening over time, 6 months to be exact, right? Depression is true depression when it's been there for that long. And it's not based on an event or a loss, right? We talked about that already. So then you have this thing where you're moving into the deeper water, if you want to use that metaphor. And the longer you stay in the deeper water, the harder it is to tread water. And then sometimes you're sinking underneath the water. And it's very difficult to breathe when you're in that position. And thoughts of ending that struggle of getting up out of that deficit can cause a person to detach so much that they think it is better off to not fight that battle, but to end that battle. Now, I said that in such a way to try to make something very severe and complicated sound more simple. You're talking about a life at this point, but we're trying to be, I don't want to be dramatic with this, and I don't want to make anybody
Thinking.
Yeah, I don't want people going home and I've diagnosed myself. I'm gonna do something bad. No, the idea here is that we're putting it in here because the reality of the continuous over long term of devaluing oneself, of isolating from social engagement, unstable sleep, unstable exercise, unstable diet, lack of enjoyment and activity. These things build up like you would expect them to.
Changes in work.
Yeah.
Changes in school.
Yeah.
Not doing as well in classes, grades slipping.
Yeah. And so now a behavioral thing or something that would be activated and you'd have to overcome it becomes part of the depression, right? It builds in on you. Now, we're not saying that, I'll say this, not everybody does this, right? We're not saying that everybody turns a sad time into depression. There's some precursors. There's definitely a genetic piece to this, everyone. So sometimes you're pre-exposed to these things and you may not have a choice on that one. And if you want to blame or thank your mom and dad, depending on how you look at it, there is a genetic component to this. That doesn't mean that if mom or dad had depression that you're stuck with it any more than if mom and dad were alcoholic, you're stuck with it. It just means that there's that variable that's there. And I always talk about variables because they add to the mix. It's not a determinant to say, yes, this is going to happen. It's a variable that you have to overcome typically, right?
Yes.
Yeah.
It helps explain the symptoms. It helps explain functioning and what's happening. When we work with clients, we take a family history. We look at family of origin because oftentimes how our families dealt with things or didn't deal with things has an impact on how we learn how to deal or not deal with something.
Right, and that's some of the other variables that she brought in because she's brilliant. The other variables that she's bringing in are environment, genetic, personality, socioeconomic factors. That environment you grew up in, you do learn from that. You get exposed to it. The younger children and up and through adolescence when you're still comparison against guardianship and peer review. But through all of those early stages, you are affected by the environment you're in. Mm-hmm. The overcoming of that is usually when you're older in that autonomous phase, that the 18 to 25, when your frontal lobe is doing its thing, you start to have a competition with what you previously were exposed to. Some people double down. And some people push away, and some people do a little bit of both, right? And 30s turn into what 20s would have been, right? Mm-hmm. So we only saying all this because, like most behavioral health, mental health concepts, they do have a tendency to build up over time. If you wait too long, it's much harder to get out of that. I'll give another visualization if I can. And this is going to be bad because a lot of people won't know what I'm talking about because, well, actually, they made a comeback. records. Records made a comeback. But in the old days, when you'd play a record, if you had a particular song that you liked a lot, you had to be, your older brother would whoop you for this. But if you put the needle down on his favorite album and you dropped it, it would damage the record, and your brother would hurt you.
Your brother,
my
would
brother,
hurt
yes,
you.
yes. But what if you had a song you liked so much that you're just from overuse, you wanted to hear that song again. BTO 4-wheel drive. I want to hear that song over and over again. And I would put the needle on that song, and I kind of knew, because eventually the groove would be slightly bigger. It would cause a record to skip if it got too big or if there was a scratch on the record. The idea behind this is that when the groove starts, it's much harder to get out of it. Depression works like this in a lot of ways. That once you start to get into the behavioral pieces of what depression can do to you, it becomes very difficult to pull yourself out of a routine that's trapping you in your depression. I would almost go so far to say it's counterintuitive, right? Because the very thing that keeps you in a depression causes you to not do what you have to do to get out of it.
Right. It becomes safe, and you start to think, it's always been this way. It's never going to change. People are going to not support me, or what. It goes unchallenged, is
Right.
what you're saying.
That's the cognitive side of it. The behavioral side of it is that it's reinforced by. So we've talked about some of the markers. You have to manage sleep, diet, and exercise. So someone who actually does have depression, or if you want to call it clinical depression, would have a difficult time managing these three things. And they have to be managed in order for you to fight the symptomatic pieces of depression. But the depression causes you to have difficulty doing that. Now I'm leading to something that a lot of people aren't going to like when I get there. The fourth thing is the isolation and the socialization, right? So the depression would cause you to have sort of a default to not necessarily engage the same way you normally would.
Right.
But you need socialization to get you to mirror off of other people, to feel connected to other people. Go ahead.
And not to get you off,
No, go
and
ahead.
we won't go down this way. I'm just addressing it. Also, part of what can be that difficulty with getting going, doing a routine, is the neurotransmitters, right?
Yep.
Change, which is why then we seek out psychiatrists to maybe help with
Which
medication.
is where I'm heading. That's going to make some. See, this is how smart she is, everyone. She knows already intuitively where this is headed. But notice we didn't start there,
Right.
which is significant.
And we do tell clients, typically, try therapy first.
Sure.
And then if therapy doesn't work, then let's try therapy and medication.
Yeah. So we have therapy and a couple more pieces before we get to the actual medication piece.
Okay.
Therapy for processing, to try to help you cognitively challenge some of the things that are in your head. Then behaviorally, adding the pieces in play that need to be added to compete with the symptomatic process of depression. So you might have to have a plan for eating, because you don't necessarily want to eat because you don't feel necessarily hungry, but you are. Got to have calorie to burn. So you have a plan around that, and you adjust how you eat. Maybe it's a lighter food, maybe it's more protein and vegetable based, less carb based. You exercise, especially if you haven't. For guys, as a side note, ADD is a terrible thing to waste.
You said that already.
Yeah, I say it all the time. For men, burning energy is huge, and it's a way for them to. We're naturally ADD anyways, and video games don't help. But just throwing it out there. But we have to burn energy to be able to stabilize. It's imperative that men burn energy and physically move. And get some of that out. Our design is different, and that energy has to be burned in a specific way. When I was working back at the hospital, just to keep going on this tangent for a minute.
Psychiatric hospital.
Yes, yes, where we met.
Not as clients.
Not as clients. You are. Did we make producer Shannon laugh?
Maybe.
So the funny thing is that when I would talk to the young guys, the boys, I always had to distract them. We either had to play chess or go outside and throw the football around. If I sat down and tried to talk to them, forget about it. Immediate resistance. But if I was able to engage in an activity with them, then they would sort of naturally start talking just as a part of whatever we were doing. So that's just a side note. So the socialization becomes huge. The fifth piece for those that have it, and I think most of our audience does, there's a faith component. And the faith component is very powerful because it allows you to do this with someone and not by yourself. To have knowledge that he is present, that he is knowing, that you lean on that is very powerful when you're competing against an internal dialogue or a behavior mechanism that's causing you to detach. Now, that being said, all of that would be worked on through a therapeutic setting prior to an antidepressant.
Yes.
Agreeable to that?
Yes, absolutely. And just again, just taking it, go to someone who specializes in psychotropic medications. Be careful who you go to.
Well, you mean a PCP, which is a primary care physician.
Not going there preferably.
Right.
Even though that's the general way, that's the general encouraged way. Go to a specialist, someone who specializes.
Tell them the titles of those people.
Psychiatrist, psychiatric nurse practitioner.
Yeah, that's the two big ones.
Those are the two big ones. Somebody who knows and who can explain doses, different medications you need, blood tests to make sure your blood levels are okay, to check at level of dosing is correct, and if they change medications, which is very complicated and challenging, you want a specialist.
Yeah, and you know, and we're not, again, I'm not an expert in it by no means. She knows far more about it than I do. But we'll talk about it a little bit. We won't go too down. But here's what we got to say about the medication. Is an antidepressant is different than a mood stabilizer. And so, you know, again, sometimes the off-brand use for mood stabilizers, they'll give it to somebody for depression. And oftentimes they'll tell people that with the depression, they might have mild anxiety. I guess we can touch on that briefly. The idea that you would have anxiety along with depression, it usually looks like this. You start to overthink the symptomatic pieces of depression because you realize there's something not happening that's negative, affecting you negatively. And the problem with that is that depression and anxiety are coming from two different places. And so it's almost like if we were to talk about severe pain. Severe pain, chronic pain can cause anxiety because you get outside of your own head because you want to get outside of your own body. Mm-hmm. And the lack of control causes you to think in a very tangential way, which can be very anxiety provoking. There's no resolution to that, very out of control. So what I'm saying is when someone does have depression, oftentimes you will see the negative self-talk that accompanies that.
Oh, for sure.
And so people will mistake that for low self-esteem, or they'll mistake someone with low self-esteem to have depression. And again, these are different concepts. Again, pointing this out to all of you so that you understand this is not one size fits all. And this is not easy, simple, oh, hey, let me look up on YouTube under some silly website that tells me we quoted some of the symptoms, right? I have these symptoms, so I have depression. Don't do that. Don't pigeonhole yourself by looking at, you understand how this stuff flows together, even with what I just said, very simplistically. It's bigger than you typically. Don't try to do it on your own.
No.
Right? Don't try to come up with your diagnosis and your treatment. It's okay to get help.
And when you seek help, be open to what the provider is telling you in terms of their experience. Don't try to talk them either into it or out of it.
Yeah.
There's some kind of objective professionalism that's saying, this is what sounds like is going on. This is what I'm seeing. Do you agree? Do you disagree? Let's come up with a plan together. And just to say this piece before I think you're going to be wrapping up.
Well, I'm still going to say one more thing about medication, but please do.
If these symptoms taken together last more than 6 months, if you're going through this stuff, guys, and these things last, and it's taking about 6 months or longer, please come get help.
Yeah.
Come see Lenny.
Well, not me particularly, but
well,
yeah.
but you could.
Potentially, yeah.
But come see a provider. Don't try to do it on your own. You're not alone. That's the whole reason we're talking about it.
Correct.
Is to normalize this stuff and to say, these are the things that can happen. Here's what you can do about it.
Yeah. Yeah, because faith-based people tend to frown upon medication. As two faith-based people, we are telling you it's not our first option. Matter of fact, we disagree with it being the first option. We disagree with you being prescribed a medication with no process to get better, to no behavioral change and no thought process and no indication of what it's supposed to look like. The medication is designed to platform you so you can do all of the behavioral things to get better. Better still, do all the behavioral things first. And if they don't stick and you're not seeing the progress that is healthy and you're still in danger and you're still struggling, then we would consider an antidepressant because, again, the complicated way that we were created, it's just not one size fits all.
No, and the whole point of doing this is to rule things out.
Yeah.
Right? We want to rule out, hey, I've tried this, and this on my own. It's not working. I need further assistance.
Right. And not that it's not working because my depression caused me to not put any effort into it. That's not it. So again, that's why you have somebody with you on the journey. Because you could see how that would be very easy, superficial. Well, I tried and it didn't work. Well, part of what inhibited you trying was you have depression. So again, the counterintuitive nature of depression is it keeps you from fully engaging in the activities that are going to help you navigate the symptoms. And so it's very ironic, but it's also very true. And so having somebody help you along the way, encouragement, validation, not hiding from other people, being able to tell loved ones that you're struggling with this. The suicide ideation typically comes when you're not sharing to help people who are healthy around you and you're isolating what you're experiencing and no one knows because most people aren't going to walk up to you and say, hey, are you depressed? Right. They might say, are you sad? They might misuse the word depression.
Right.
And so it's great to be able to say, I am sad, but in this case, I'm sad because...
something situational.
Something situational. My favorite TV show got canceled, and so I'm sad.
Right.
My favorite team lost. But different if they say, "Are you sad?" and you say, "Yeah, I have been for some time, and I'm not sure why." That's a great time to encourage somebody. Have you processed this with anybody? Have you talked to anybody about it?
And just to go back to this, when you were talking about medication, sometimes when you rule out, I've tried therapy, I've tried talk therapy, I've tried CBT, and I'm ruling out just that on its own, solely. Medication can help some clients do CBT and do talk therapy.
Yeah.
Meaning it can help them engage in that process
or regulate their sleep, exercise 3 to 4 times for 30 minutes a week. Manage the diet so you're not eating heavy foods late at night. The sleep, guys, just real quick on the sleep because it's closely related to depression. 9 hours max. You're going past 9, you're going into another sleep cycle. You're confusing your body because your brain will dominate and say you're still sleepy, go back to bed. The grogginess you feel after oversleeping is because you're still in that same sleep cycle. So you're looking at 16 hours as opposed to the 8 or 9 you should have got. Now you're into the next, you're going to be groggy. And you're going to throw yourself off for the next time you go to bed because your body's saying, well, it's time to be awake. We haven't been awake long enough. Understand the dynamic of this. You can't make sleep back up. You have a bad night, you only got 5 hours. You don't sleep for 12 the next time thinking you've balanced it out. You're in a new circadian rhythm. You're in a new rhythm. You're not in the old one anymore. You're not going to make up for that. You got to start fresh again.
So sleep hygiene.
Sleep hygiene.
Doing a routine, maybe taking a bath, drinking tea, doing some stretches or yoga before bed each night to help you get in the rhythm of sleeping, going to bed at the same time, waking up about sleep hygiene.
You've got, it's basically sleep hygiene. You can look it up. I'm sure it's on the web. You can probably ask one of those stupid AIs to tell you about it. I'm not a fan of all that AI crap. I'm okay with saying that. But listen, we just want to make sure people understand that it's not everybody has depression because you're sad. Not everybody who's sad is immune to depression. And the idea here is that if talking about it is the first step, and oftentimes it actually does work because you're getting outside of yourself. And along with the talking, you're going to modify, you're going to start learning how to manage those first 3 things: sleep, diet, exercise. You're going to start reaching out to socialize. For parents, that means someone who isn't 2, right? Someone who's an adult, right? Because oftentimes parents will only socialize with their children and they're not getting adult socialization.
Right.
And then fifth, if you have it, not in order of importance, but if you have faith in your life, you should be accessing it. And on the opposite hand would be an antidepressant when needed. And it's important to check in with somebody to assess on whether or not you need it and not just go, I'm going to get a medication, everything's going to get better. Let me give one more kind of realization to this so people understand. And then I'll give you the final thought, dear. Medication is doing something in the brain, and not to get too technical, to either level out, increase, decrease serotonin connection between, like playing catch, a receptor and a receiver. And so on a basic level, what you're saying is that a medication can very much work, and then all of a sudden you have a new sense of clarity. That new sense of clarity, if it doesn't have a program to engage in, can increase the negative and disconnected thought process in and of itself. That's dangerous, right? So it's like saying, you give me muscles like Captain America, and I've never exercised before, and so now I'm using the muscles and I'm hurting myself because I'm pushing too much weight, or I'm, gripping onto people too hard because I didn't realize I now have these new muscles. So it's a build up to this. It's you have an acuity in your brain that you didn't before, and if you didn't have a plan, that can spiral you just like anything else, okay? So that's why we tell people you shouldn't be just taking medication without any guidance. She said that earlier. You should go see somebody as a specialist so they can tell you the ins and outs of it. Primary care physicians, I'm not trying to knock them. They have permission to prescribe you antidepressants and anti-anxiety and mood stabilizers and all this other stuff.
But they're generalists.
And that's what their degree's in. And so they have a little bit of knowledge. They do a residency, right? But it's not their whole kit, the whole thing that they do. So maybe pause long enough to get a referral to somebody so you can get some expert opinion on that, so you can make an informed decision, right? You don't bring your taxes to the baker.
I don't.
No, I don't either. Anything you want to close with?
Just this idea that if it goes from 1 or 2 days a week where you're not sleeping, you're crying a lot, you're not eating, it can very, very quickly escalate and snowball to every day. So it's important to notice these things when they start happening and when things start changing, because once it gets to every day of the week, 7 days a week, not eating, not sleeping, crying,
might be too late.
It's just that much harder to get out. It's that record thing, right? That groove has become so deep that you're going to need more. So try to do something when it's just starting, as opposed to waiting until it gets so bad that it's more difficult.
And it's like that with a lot of things, a lot of the different disorders. So we encourage you to talk to somebody, reach out to somebody. We want that for you, so we encourage you to do that. And thank you very much for joining us.
Thank you for your service.
Oh, my gosh. All right, bye, everybody. Thanks for joining us on Distorted. Follow us however you can, but primarily we're on YouTube, Rumble, Apple Pod, and Spotify. Add a comment, share it with your friends. We appreciate you.